So now that's good. Well, this you get a high speed on, and you don't have to fuss with it. And nobody goes there yet. So, but they're trying to put up the train parks.
I don't
build
enough
big
money
jumps.
to buy you all.
So when I come up, I'll have the big hits for you. Yeah. Me too.
You see how I dress?
What's interesting is when you get off the condo, you're literally on the patio of the residence. So there's no walk. You literally get off and you're on the patio to the rendezvous.
Really? You always think so?
No, that I understand. Absolutely.
It's done funny. They're supposed to open it Friday and they didn't because it was too windy. So they opened it Saturday. Yeah, we had an umbrella on our porch that's going to be like flew around and all this stuff.
Yeah, that's what I said. Yeah, it could be. It's still asthma.
We had it taken down and it was laying on the ground. We didn't think it was going to get blown around.
It's very asthmatic. That's what I said. That's what I was thinking. Yeah.
That smoke.
You should have a chest extract.
Yeah, I agree.
Did you have that chest extract already?
Because you're not even compromised, so this could just be very well. Like, low lying pneumonia.
No, Len.
She's in Hawaii.
Too bad.
I don't believe you. Okay. You sound like hell.
And he is that house.
You should have a chest. You should have
You should have a chest extract.
Yeah. He's looking for cavitary lesions.
Should we have you introduce yourself and just go on?
Alright, let's get started. Len's in Hawaii.
I'm sure he signed in though, right?
Yeah, I'm sure he's watching right now for us. We have Nick today. He's my go-to dermatologist for my stupid questions asking, so he graciously agreed to talk to us again this year. So thanks for coming.
Yeah, thanks for having me again. It's been a while since I've been here, and I appreciate the opportunity. I'm one of the dermatologists here at Roosevelt. I've been at Roosevelt for a little over 3 years now. I was at the VA for 4 years before that. I'm a product of the University of Washington, did medical school here, and my internal medicine residency here, and then saw the light decided to do derm, and also did that here. So I've been around a long time. I don't have any relevant disclosures. I toyed around with sort of different titles, but basically what I want to talk about today is the immune system, which you guys know a lot more about than I do, and how it may relate to chronic itching. And this topic was kind of came to mind based on two patients. One specifically that I share with Drew, with another one who I think has some similar changes in their immune parameters that I share with Dr. Compton. So no relevant disclosures. I think today's talk is boiled down to a couple of things. One is I think immune dysregulation may contribute to chronic itch, and the thing that was striking about this first patient that we'll talk about is even in patients without significant evidence of significant skin disease or inflammation in the skin, and then that immune suppression may be helpful even in those patients. So itch, what is itch? Itch is a sensation that produces a desire to scratch. I've always felt it sort of mean to tell patients don't itch or don't scratch because that's what itch is. It makes you want to scratch. So our job is to try to figure out why they're itchy and to try to help them. It's the most common skin complaint in outpatient clinics, and for most people it's transient and goes away. But for some percentage of patients, up to 22% lifetime prevalence, it can be chronic and fairly debilitating. Shared this already. In terms of quality of life, its impact is similar to that for pain. I'm not going to go through this whole slide, but there's a lot of mediators of itch. It's complex. These are some, a partial list of some of the itch mediators and receptors that are known. And though we know a lot about itch, there's still a lot to learn. Some of these act directly, while others, like prostaglandins, act by potentiating nerves for response to histamine, for example. Some of these act peripherally, some of these act centrally, and we don't have a great understanding on how they all work. Interestingly, IL-31 is produced mainly by Th2 cells, but also by mast cells, and induces pruritus by modulating the functions of some of the C fibers. We'll talk a little bit more about some of this a little bit later on. So when we're talking about itch, and I think I've talked to you guys about this before a few years ago, but when we're talking about itch, we kind of think about it in three big groups, three categories. And one is, do they have inflamed or diseased skin? So what's the background of their skin that the itch is occurring on? The second one is skin that has secondary changes. So these are things like prurigo nodules or lichen simplex chronicus, that sort of macular amyloidosis that you see in the interscapular back in patients who have notalgia paresthetica. And then finally, this itch that's on non-inflamed or non-diseased skin. Kind of underneath these large groups, we think of itch in four other categories. One, pruritusceptive itch, so itch that is caused by skin, primary skin problem. Systemic itch, so itch that's related to renal disease or hepatic disease. Neuropathic itch, so this would be like notalgia paresthetica on the back, brachioradial pruritus, which you see in the brachioradial distribution, or even patients who have bad peripheral neuropathy, they can get truncal itch related to their neuropathy. And then the final one is psychogenic itch. So these are patients whose itch really is just in their head. It's also important to remember that about a quarter to a third of patients have itch for several different reasons. So they may have liver disease and they've got dry skin. So there's mixed things. So the first case, and I think the case that really got me thinking about this, is a 52-year-old woman. Her itching began in 2015 after some kind of stressful life events. It started in small areas, but then has become more generalized over time. She has absolutely no skin findings. I have seen her once. She had a rash, but it was unrelated. It was an evanescent eruption. No known triggers, and no history of frequent infections. She's got a past medical history of quite a bit of psychiatric disease with depression and anxiety. She follows with a psychiatrist. She's got some PTSD from childhood stuff, gastroparesis with a neurostimulator, and then a recent diagnosis. This is after we've been seeing her for a while, of ankylosing spondylitis. I think she's on quite a bit of meds, a lot of psychiatric meds, and then she recently started ECT for depression. That's new. So this patient, I'll talk about her later after I discuss some of the findings in the literature that I found, but she's been really difficult. And I thought when I first saw her with all her psychiatric stuff and no skin stuff, I really thought that she probably had at least in part some psychogenic itch. The thing that's really interesting about her is that the only things that have been really helpful for her itch have been narrowband UVB, sort of, and then prednisone. So when she gets on prednisone, her itch totally goes away. And so, I'll talk more about that in a little bit. So the second case is a 75-year-old man who's had a lot of years of waxing and waning cutaneous eruption, super itchy. And we've had a fairly extensive workup, which I'll talk about later, that hasn't really identified a cause. But he's different in that he's got rash. He's got an identifiable skin findings. He denies any personal family history of atrophy. He's got vascular disease, obstructive sleep apnea, and coronary disease, and the appropriate medications associated with those. And then this is what his skin looks like. And he has very, kind of variations of this, but mainly he's got some pink to red erythematous plaques and papules. Some of them with scale. He's got some hyperpigmentation from old stuff. He just scratches a lot. Itchy. And in him, things that have been helpful are topical steroids, prednisone. So kind of the same things. Like he gets better with anti-inflammatories. So it makes sense that he would get better with anti-inflammatories, in part, right? Because we can see on his skin that he's got inflammation. Well, both of these patients, I would argue, have chronic idiopathic pruritus, and that's just chronic itch for greater than 6 weeks, so not very long, with an unknown cause, with no known etiology. To get to that diagnosis, of course, you have to rule out all kinds of things. Scabies with a scabies prep. Look for metabolic and hematologic causes. With a lab workup. Look for dry skin. I mean, as we get older, we're talking about immune senescence a little bit, but as our skin also sort of senesces as we get older. We make less moisturizers naturally in our skin. So when we have, which makes less of a, gives us dry skin. Dry skin is less of a barrier. We're more likely to be exposed to antigens that can cause itch and dermatitis. So looking at your patients who are itchy, trying to maximize their emollients is really important. So does it work all the time? Well, absolutely not. But it's certainly a piece of a puzzle to look into. So physical exam would be really aggressive with emollients. Creams are better than lotions. Ointments are better than creams. So lotion's anything you pump out of a bottle. Cream's anything you scoop out of a tub or squeeze out of a tube. That's what I tell patients. So, metabolic stuff. HIV is another reason for chronic itching. CTCL is a thing to consider. It's can be difficult to diagnose. Things you might look for that would be some epidermal atrophy, and then sort of relative hair loss in the areas that are involved. I don't expect you guys to have to diagnose CTCL, but just if it's on your radar. Sometimes patch testing can be done, and the gentleman, the 75-year-old, has had patch testing. Usually, if somebody's itch is out of proportion to what you see on their skin, it's an inside job rather than an outside job. So patch testing in that patient probably not going to be all that useful. Medications, right? There's medications that can cause just itching, medications that can cause rash.
Do you find anything on a blind biopsy when you biopsy these people?
That's a really good question. I'll talk about that in a little bit. There's a couple of places that I gathered, a couple of clinics that I gathered data from mainly on this for this talk, and one is at the Center for Study of Itch in St. Louis, and another is at Emory University, where they've got a clinic for management of severe itch. And they both say that on biopsy, both clinical morphology, so what is it, are they papules without scale, indicating some dermal hypersensitivity, or are they more eczematous sort of morphology? So clinical morphology and histopathology really don't determine whether they're going to respond to treatment or not. So Swirlick, who's at Emory, they do the biopsies, but mainly to rule out other things. I found it's not all that helpful.
Okay.
And even on, well, I'll talk about that. So medications, and then thinking about any primary diagnosable skin conditions, psoriasis, atopic dermatitis, trying to find those. So once you rule all that stuff out, you're kind of at chronic idiopathic pruritus. And I see a lot of patients like this now. I mean, I see a lot of patients that I end up calling dermal hypersensitivity reaction, because on biopsy they've got maybe a little bit of spongiosis in the epidermis, but they mostly have perivascular lymphocytic infiltration with eosinophils in the dermis. And sometimes they're really hard to know what to do with. Usually historically what I thought is, well, dermal hypersensitivity typically is bugs, drugs, id reaction, or some intrinsic like atopic dermatitis. Now I'm thinking more about this immune senescence as a possible trigger. So immune senescence. So this is sort of age-associated failing of the systemic immunity, and it's also another term that's kind of used as inflamed aging, and it's this idea that as we age, our immune system changes to a slightly more dysregulated inflammatory state. It appears to be associated with increased risk of infection. Also, sort of inappropriate responses to stressors, such as antigens and chemicals, etc. The senescent cellular phenotype is accompanied by upregulation of several kind of signature markers of DNA damage response, secretion of pro-inflammatory cytokines like IL-6 and IL-8, also proteases and the other proteins that are globally called the senescence-associated secretory phenotype. So what we see is that overall, the overall factors of kind of what causes senescence is not really well understood. But for immunity, what we see is that the adaptive immune system is much more effective than the innate immune system, and that it's mainly the T cell compartment that's affected. B cells are affected as well, but mainly the T cell compartment. And what we see is that we have a decrease in antigen experience in naive cells, and that really starts once the thymus starts to involute. But we also have an increase in the antigen experienced memory cells and effector T cells, and all of this causes a decrease in the T cell repertoire. I'm not an immunologist, so a lot of this doesn't make a whole lot of sense to me, but what it seems like is that in some of these patients, they get skewed kind of to a Th2 response. So their Th1 kind of becomes less active, their Th2 becomes a little more active, and it looks like Th17 remains fairly unaffected. So this is a group of 4 patients that were reported out by Dr. Kim and his group at the Center for the Study of Itch at Washington University in St. Louis. And they were looking at kind of these patients who have chronic idiopathic pruritus. So they've looked and they can't find any reason for them to have itching. They've had itching for sort of 6 months to 5 years, and their age range is 75 to 90, so older. And they wanted to look and see sort of what is their what's their immune system like. And what they found is that 3 of the 4. Well, let me step back first and just say, so this was fairly typical of the patient. Not a whole lot of skin disease. And there's a little bit of rash up here, but they were pretty itchy all over. So fairly consistent with it was fairly consistent among patients. But when they biopsied that small little area, they did see quite a bit of inflammation. This is pretty robust, perivascular superficial with eosinophils. And when they looked at their sort of immunity, what they found was that a lot of them had some abnormal parameters. So 3 or 4 had peripheral eosinophilia. Half of them had eosinophils on their biopsy. 3 had elevated IgE levels, suggesting this sort of skewing to the Th2 response. They also had low CD8 cells, not all of them, but a majority of them did, suggesting maybe a waning of the T1 immunity. And 3 or 4 also had low CD19 cells, so B cells too. So this sort of weird kind of immune parameter abnormalities. And so what I mean, they said, and they don't know, of course, but how is this related to their itching? Is it related at all, or did it come before, did it come after? I don't know. It was interesting anyway. So Swirlick and his group at Emory have been looking at itch for kind of a long time, and they have several articles out on that. But one I thought was kind of interesting was one specifically looking at kind of azathioprine for chronic idiopathic itch, suggesting again that there's some immune-mediated reason for them to be having itch. And this is, and again, this is in patients with some skin disease, but some patients that don't have much evidence clinically of skin disease. So all these patients had severe itch, chronic idiopathic. So they looked for other reasons for them to have itch and couldn't find any itch. Most of them were older, so 54 was their sort of mean age at the time of getting the azathioprine. Most of them were women. 85% had itch for greater than a year. And when they look at the sort of, this is just a visual analog scale of itch. So going from 0 to 10, pre-treatment, they were pretty miserable. They had almost intractable itch. But then after treatment, this is retrospective. After treatment, they don't talk about how long it took to get there, but their itch was significantly improved. And then they were treated for, up to sort of 16 months. Well, all of these patients had transient improvement with oral steroids. So this group in Emory, what they'll commonly do is have patients, and these aren't just your typical, patient. They're being referred to a center for itch. So they've had quite a bit of a workup, and they've had itch usually for quite a long time. It's been very refractory to lots of things, right? I mean, we all tried emollients, topical steroids, and antihistamines, and those kinds of things. But
do you know what the dose of azathioprine was?
yeah, so their range. Well, so they do TPMT, and they base it on the TPMT. They usually start at 100.
Metabolic profiling.
Yeah, the thyrapurine methyltransferase level. And they usually start at 150 and then sort of adjust from there. There's another article that they wrote about azathioprine, and it sounds like the reason they like it is it's cheap, it's once a day dosing, and then you can check metabolites. And so they do a lot of metabolite checking to see sort of if they're not responding, maybe it's because they don't have enough of the active metabolite. So they'll adjust doses based on
probably do it with
that.
methotrexate too. I wonder if they tried that.
Yeah, so they talk about using methotrexate, mycophenolate, and cyclosporin. This particular group likes azathioprine because of the ease of dosing and cost, etc. Yeah.
And when they followed them up, they had some other immunologic parameters that you sort of didn't say anything about, like they're all IgG or IgM deficient. Did those change after therapy?
It's a good question. So in the Kim article, they don't talk about it. They don't mention that. And then in Swirlich's articles, he doesn't really talk about the T cell subsets or IG levels.
That's interesting.
Yeah. So unknown to me. Maybe known to somebody. So, as you can imagine, with azathioprine, there's lots of side effects. And in fact, 65% of patients had side effects. 40 patients discontinued medicine. 8 patients discontinued, but then went back on sometime later after a holiday and tolerated it well. 3 patients were put on 6-thiolguanine, and 28 patients were put on MMF. They didn't present the data, but they comment that the patients that were on MMF did just as well as the patients on azathioprine. I think the reason they don't like MMF is much because of cost. But this is a single institution retrospective, but it does suggest that in a population of patients with chronic idiopathic pruritus, immune suppression may be helpful. Which again, I think suggests that there's some immune-mediated reason for their itch, even if they don't have significant evidence of inflammation on their clinical exam in terms of their skin. And then I mentioned before, they talk about in this article and then in other articles that they have found skin morphology and histopathology not really be predictive of response. But one thing that they do think is predictive of response is this trial. They'll do a trial of 2 weeks of a prednisone taper. And if patients tend to get better with that, they feel pretty strongly that they're going to get better with immune suppression.
How many of your itch patients don't get better with prednisone? I find that number pretty small.
Yeah, probably. Although I don't use prednisone. I don't use prednisone a lot. I try to get them onto something else usually. because in part, I mean, if I present it like this, like, look, we're going to try this 2-week trial, and if it works, then we're going to consider something else. Then that's I think that's probably a better approach. What I worry about is giving somebody some prednisone, they get way better, and then they're just salivating for prednisone. And kind of like this other patient that we had. I mean, the guy with the rash. He's using about 2 or 3 tubs of triamcinolone every month, and he's got atrophy, and I can't get him to do anything different. So we have some patients that have some abnormal immune parameters based on some blood tests. We have we have a group in Emory that are giving patients with chronic idiopathic pruritus and immune suppression, and they're getting better. We have this idea of immune senescence, which creates maybe more of a Th2 response. And so, is there a connection? I mean, IL-31 is produced by Th2 T cells, so there's maybe a little connection. But IL-31 seems to be more associated with acute itch rather than chronic itch. This group in St. Louis looked at, they did a series of studies that were presented in this article from Cell, looking at kind of the neuroimmune interface, and found some interesting things. So in atopic dermatitis, we know that Th2 cytokines, IL-4, IL-5, and IL-13 are known to drive inflammation. And in mice that overexpress IL-4 and 13, they develop an atopic-like sort of skin disease with a pretty robust chronic itch. But the mechanisms by which these pro-inflammatory mediators promote itch are not really clear. So these guys looked at mouse and some human data to look at this sort of again neuroimmune interface. And what they found was that when they took mouse and human sensory cells from the dorsal root ganglion, they found that they do express receptors for IL-4 and IL-13, as well as IL-31, but not IL-5, and that those sensory neurons respond to their ligand. They also found that those fibers seem to be kind of the same fibers, the same neurons that are included in sort of previously identified sort of itch pathways, sort of like for histamine and TSLP. So it looks like it's activating these fairly typical sort of photoreceptive neurons, if you will. They found that IL-4 IL-4 and IL-13 didn't act as acute itch mediators like histamine. What they found was that IL-4 sort of potentiates the nerves. If you expose the neurons to IL-4 before you expose them to like histamine, the neuronal response is much greater than if you expose to say histamine and then IL-4 later, or just IL-4 alone. If you expose the neurons at the same time, it's also much greater. So it seems like they potentiate the neuron to sort of respond more robustly to sort of normal classical pruritogens. Then they also found that if you sort of knock out the IL-4 receptor on these neurons, your itch response is abrogated, which makes some sort of sense. Again, I'm not an immunologist, I'm not a scientist either. So I don't do science at all. It seemed like everything that they were doing was pretty pretty good, and the article was easy to read, so I found that helpful.
No science.
Yeah, that's right. What they also found was that it appears as though so JAK1, cytokines like Th2 cytokines in immune cells work through the JAK pathway, and they found that JAK1 seems to be enriched in these neurons as well, these sensory neurons in the dorsal root ganglion, and that the IL-4 receptor seems to signal into the neuron through a JAK pathway. So if you knock out that JAK, I don't know really how they did it, but that the response is abrogated, suggesting that JAK's important in that pathway. And then there are some clinical studies that demonstrate or that suggest that JAK inhibitors can inhibit chronic itch. So JAK inhibitors, tofacitinib, can be helpful in patients with atopic dermatitis. And this group also looked at 5 patients, again with chronic idiopathic itch, and gave them off-label tofacitinib, and within a month their itch score had improved significantly. So it appears as though we have, again, these patients that can have an immune-mediated itch without necessarily having a lot of skin inflammation, that giving some of these patients immune suppression can be helpful, suggesting an immune-mediated sort of pathway, and then that the Th2 cytokines can potentiate sort of classical prurigens at the neuroimmune interface, maybe lend some credence to this idea of immune senescence and Th2 activity. So in these older patients that we see with itch, maybe that we can't find a reason for. Maybe some of it is this. I don't know. I don't know. I think it's really interesting, but I haven't tried out any of these. Yeah.
I just had a question for those older patients with immune senescence. What's their treatment? Were they on medications that probably can affect their immune system, or they said there's nothing about them that's unique?
Well, I mean, yeah. In these articles, they don't describe their medication lists, and so I just have to trust that they looked at those things, and ruled out all those other things. I mean, maybe I'm just a trusting person. That's why I don't do science. But I think these guys these people are working at centers that have expertise in itch, and so I would make the assumption that they would look at those kinds of things and rule those things out before calling them chronic idiopathic pruritus. But it's a risk that I'm wrong.
Okay.
Yeah. So I don't know. I mean, I'll talk about it in a second. But so I'm going to get back to the cases. This woman, sort of 3 years of itching, no skin findings. She had a fairly decent workup, I think. I never did a skin biopsy of her skin for H&E because she didn't have much rash, but I did wonder about small fiber neuropathy because she had this sort of gastroparesis thing too, and she had that biopsy done by neurology. I didn't find any abnormalities. She's had normal CBC with diff, normal comprehensive metabolic panel, tryptase, head rate, etc. Immune fixation, her IgE was normal, all this was normal. When she went down to St. Louis, she was found to have low IG levels, and maybe they'd been done here too, but I don't remember. She found to have low IG levels, low kind of across the board T cell subsets, as well as low B cells. And then there's some question about maybe common variable immunodeficiency, though she has no history of autoimmune disease. She's got ankylosing spondylitis. She has no history of infections. So when she came back from St. Louis, the recommendation was IVIG or Azathioprine, and didn't really get, which is why I started to sort of look into this a little bit and see what they're talking about. There's no data. I can't find any data except for one article in the 90s that talks about IVIG for itch, and that was in a patient who had malignancy-associated dermatomyositis, and it seemed like it was helpful for that patient. But I can't find any other. I talked with Dr. Kim over the phone about this patient, and he has said, well, we've been seeing these patients with itch that have some sort of immune dysregulation, and what we've been treating with immune suppression, they seem to get better. He said, for her, I would try IVIG, and if that didn't work, then I would try Azathioprine. So I don't know. Maybe he's got some internal personal data on the IVIG, but I certainly couldn't find any. So she's tried a lot of things, and I've tried a lot of things with her to treat her itch. Tried a lot of those atypical things for itch. None of them really seemed to work. She got a short bit of mycophenolate, and the reason I thought mycophenolate was because she had told me, she said, I get better when I get prednisone. And I thought, well, when I'm treating patients who have skin disease and that history of getting better with prednisone, it's fairly common they'll get better with MMF. And so I thought, well, maybe we can try it. She said, no, I don't. She got the prescription and said, no, I don't want to do it. So, okay, well, why don't you continue with the phototherapy then? And then I talked with her maybe a month or so later, and she was taking the mycophenolate without getting any labs. And I said, you need to stop it. Like, you're not, like, I need to be able to, like, monitor you and trust you, and so you need to stop. So she wasn't really on very, very long, so I don't know if it would have been helpful or not. She had been on cyclosporin for a short period of time before I ever met her. But we tried a lot. I tried a lot of those atypical things that I read about for itch that's sort of uncontrolled, especially itch without rash. So on Dansitron, she thought she got maybe a little bit better for a while. Naltrexone didn't do anything. She's been on gabapentin and Lyrica and all these other things. The only thing that seems to have been helpful for her so far is prednisone and narrowband UVB. She does have an immunologist, allergy immunologist that she sees that she has seen at Virginia Mason, and he felt that her low IG levels was maybe related to lamotrigine. And again, I couldn't find any really information about that. And then she had, and Drew, maybe you can comment, she had a bunch of testing for pneumococcal response, and they all looked like she didn't respond to me, like, I don't know her many of the big.
Can't remember exactly, but yeah, she didn't have a great response.
And so, can you talk about? I might put you on the spot. Can you talk a little bit about what does that
Just looks at the specific response to polysaccharides. That's something we always do for initial immune workup. But yeah, she's interesting. She's absolutely miserable. She was tearful throughout the whole time I saw her. So we are applying for IVIG, at least to try and get her a trial.
Yeah.
I'm like you. I looked for data. I didn't find anything, but in her case, given how miserable, this is debilitating for her. So we're trying to get a trial approved for. I'm lobbying for a 3 to 6 month trial to see if that improves her symptoms at all, just because she is so miserable. But yeah, that's part of the normal kind of immune workup.
Does that suggest to you any sort of primary thing, or is that just consistent with the IG levels that we see?
You know, if she had infections, she would meet criteria for common variable immunodeficiency. She just doesn't. That's the bizarre part about her. But she has no other. Again, if she had infectious issues, she would meet criteria for CVID. She just doesn't have any of those. So we'll see if we can get a trial approved. But I'm hoping to get 3 to 6 months, and at that point, we know whether or not it's effective.
Did you vaccinate her and repeated the titers, or?
I can't remember. She had it before. I can't remember what time frame she had the.
I think her outside
previous
immunologist did give her a vaccine and had her come back 2 months later to check for a response.
It was not a robust response.
I also looked because of this. I looked to see if CVID is associated with itch, and I don't see that either. And so, there's obviously a lot of things we don't understand about itch and the immune system, and more than I don't understand. But yeah.
Well, the neurologists use high-dose IVIG to treat multiple sclerosis, and their comment was it was always an immunosuppressant. So it sort of is an immunosuppressant in a safe situation with this woman who you could kill pretty easily with an infection. So, but they use 100 grams like 5 days in a row. They do huge dose IgG, and they get some people in MS2 into remission that way. So that's sort of an interesting, I don't know if it's an aside or just they're winging it. But the other question I have is, since you commented about sensory nerves, has anybody tried for these really bad itch people to do a block and have one of the physiatrists go in there and block one of the sensory nerve roots and see if they can take out the cervical sympathetics or parasympathetics and see if that affects their itch?
It's a good question. I do that. That has been described for scrotal itching. that's intractable, or you don't have a cause. So yeah, I guess so.
Because if it's all neurogenic, I mean, you think if you block it, you'd be able to stop the itch. Sorry, Bill.
From your cell paper that you showed, it seemed like for RF as a signaling pathway, it could be at least in mouse studies, it would be seemed like a more direct approach to get a trial with dupilumab too.
Right, exactly. Yeah,
You know, if you, so many of these just idiopathic, are there any case reports there in this where they've ruled out and where they don't have coexistent atopic dermatitis?
That's an excellent question, and I didn't look, but I will. I'll let you know. Yeah. No, that's a good question. For her, I was thinking it'd be interesting to look at JAK inhibitor. But I mean, as you say that, I mean, I think dupilumab certainly has a safer side effect profile than the JAK inhibitors, and so it'd be an interesting pathway to look into. So for her, I thought, gosh, it'd be interesting to see what happens with JAK pathway, but I don't like the. Any other comments on her? So then our second patient who has obvious skin disease, been going on for a long time, waxes and wanes. He's had patch testing, really extensive patch testing with Mark Antizano over Polyclinic, and was only found to have an allergy to a chemical sunscreen product. He's had pathology because he has skin rash, and he's had atypical lymphocytic dermal infiltrate at least a couple of times. When I first saw him, he was coming kind of from Polyclinic again, I think, and outside, so I wanted to repeat some of this testing to make sure he didn't have a smoldering lymphoma. And again, it showed an atypical lymphocytic infiltrate. The T-cell gene rearrangement studies are polyclonal, and flow cytometry of his blood and his skin have been negative twice. His other biopsies have shown psoriasiform and spongiatic dermatitis with eosinophils. And I think suggesting a sort of dermal hypersensitivity type reaction. He had direct immunofluorescence that was negative, looking for BP, both pemphigoid. I talked about those. His IgA and IgG levels were normal, but I'll show his IgM level was low. He's got peripheral eosinophilia as well. We haven't checked an IgE level on him. Might be interesting to see, but he's got low IgM. He's got a new monoclonal antibody that needs a little bit more evaluation. He's had lymphopenia for a while, and we had him see oncology, and they thought that maybe it was related to prolonged use of prednisone. He was getting prednisone, topical steroids, and then intramuscular triamcinolone as well, and they thought that maybe that was related to that. Though his T cell subsets are down, and his B cells are down as well. So though different, very different clinical presentation, kind of similar lab evaluation, and so whoops, wrong way. Antihistamines, haven't really been helpful for him. He gets tons, literally tons of triamcinolone, and he thought maybe gabapentin helped him a little bit, so we have tried to up the dose a little bit on that, and then he gets better with prednisone and triamcinolone. And I've tried to get him to consider more immune suppression, and he kept saying that he wanted to see allergy first, and now he has. And so maybe we'll be able to move forward with something around it. So these two patients do have some similarities. They've got chronic idiopathic pruritus. They've got chronic itch that I can't explain, and then they both have this sort of immune deficiency. Yet their clinical presentation is so different. So I just wonder if there's something that we can learn from them that can help moving forward with other patients. I mean, one thing that I think to me is fairly clear is that this grouping of patients in either primary skin disease or secondary skin disease is probably artificial and not really a fruitful sort of errand, I think. And then, I guess I had to think more about in patients with chronic itch, looking more into their immune system and trying to gather some more more information and maybe just more anecdotal data about these patients, and then trying to follow their immune parameters as we treat them and see if they improve at all. So I don't know really where these two are on this whole spectrum, but I think that both of them, with the response to prednisone, and certainly the one with skin disease, suggest there's some immune-mediated reason for their itch. But other than that, I don't have big conclusions about that.
Since you have that one biopsy that shows psoriasiform dermatitis, you might be able to try and push him for a trial if you know that.
Yeah, I mean, so all psoriasiform means is that when they look at it under the microscope, the epidermis is thickened but in an irregular way. So and that is commonly seen in chronic itching, where your epidermis gets thickened. So when you see psoriasiform under the histopathology, I wouldn't necessarily think psoriasis.
And I was just thinking of a way for you to get a monoclonal antibody approved.
Yeah, right.
Hope that they don't
Right.
look past it and say,
Right.
yes, psoriaform dermatitis. That's right. We'll approve it.
And in the early clinical trials with the anti-IL-31, have those used as any of these patients?
I don't think they've been. Probably have been used in some chronic idiopathic pruritus patients, not in the papers that I looked at. But it would make sense. I think it would make sense to block that itch mediator for sure. Okay, so chronic idiopathic pruritus itching can be debilitating. We still need a lot of work on understanding the mechanisms and pathways that cause itch and then maintain itch over time. I think there is some role in immune dysregulation in chronic idiopathic pruritus. What that is exactly is sort of unclear, but maybe there's a Th2 predominance that helps sort of stimulate that, as seen through IL-4 and IL-13 and the sort of neuroimmune interface. Immune suppression, including JAK inhibition, may hold some promise for some of these patients. But again, I think it's sort of wide open, and I'm really encouraged that there are places that are really looking at itch and trying to understand itch a little bit better, and places that we can send patients to get some expertise and help. That's it. Thanks for listening.
Do you have any idea how many of those chronic idiopathic itch people in clinics have this type of immune response?
I don't know exactly. All I know is what they do.
People were
Exactly.
just
Yeah, exactly. But I don't know. I didn't contact Swirlick at all to get this sort of personal experience. He doesn't put that information in his paper. So I don't know if they hadn't been looking at it before, and Kim was the first one to kind of start looking at it. I don't know the answer. So it's something that I think I'm going to start looking into.
It's pretty gutsy immunosuppressant. Big cojones to do something like that. So that's,
There's a reason why it's just
that's sort of scary. We're just going to immunosuppress people.
and therefore, it's free, right? Like when you go to it, something like that,
Which ironic.
I remember I had one today.
Yeah, right. I was going to talk a little bit about that. There's the Azathioprine, I think is what it's called, for pruritus and atopic dermatitis. I took my dog in for some skin issues a couple weeks ago, and he got a shot of
okay, so yeah, I took it because I was like, the first one.
You actually have to give
Well, it's that rosacea,
it's probably
ivermectin. Yeah, you can get horseworm paste for $12 for
sorry?
60 grams, and it's $500 for a 30 milligram tube. So basically, if you look at the biopsies of chronic idiopathic urticaria, you also see perivascular lymphocytic infiltrates. So what the biopsies suggest that they're very similar.
That's a very good question. But seriously, for this as well, have just been easier, so like,
Now, do you want to see any more of these patients? So, because when I get to this point, I'm going to start checking my blood tests in everybody. But before I would immunosuppress them, I would probably want you to say, yeah, this is a good idea. Or, I'm going to do that. I don't get any help from my I just found out history of what's Eugenol, isoeugenol, and benzoyl.
So I I know when you say yellow. That's a beautiful case. Like just
So that's really interesting. Moved there to New Harbor, and they sold their house up here.
Hey guys. I can wrap that up. I'll take it. Are you taking them up?
I was going to take one.
Okay.
Yeah. But, so that's very interesting. I mean, I know the population over acceptance is on the
Maybe next week.
It is. I think I'm in ferry now, going over to Bremerton. Passengers, interesting possibility.
Well, we can drive there southward from Port Orchard, over Bremerton, and
yeah, you can do the same thing in here. That kind of coffee.
oh really?
Oh, are you?
You get to play just about anywhere, but I cover the whole West Coast.
Oh, wow.
Yeah, so I go down to San Diego,
Yeah.
Salt Lake City, Washington. Yeah.
Really?
If you like
That's
it.
a huge church.
I got a huge
He must be bold.
I love it though. It's just
Right, yeah.
Have you been
Almost.
It's just
Oh, yeah, I have.
You should try something.
Really, the part of me that really would like to go there. I've been there a number of times over the years, and I really like it. It's just a great job. But again, the situation with my youngest one. Yeah, no, I know. Yeah.
But I'm not sick. Don't have fever.
How long have you been back?
Much better now.
Oh wow.
I
Oh, so you're not, yeah, you don't have a.
So I knew what I did.
Yeah, then you see your patients, and they're like, oh no.
Right, and then I'm allergic to it.
Yeah, it's
Nice to meet you. Thanks. I just had to grab the food before it ran away.
Yeah, sure.
grab that.
Yeah.
Well, hopefully everything works out.
How are you?
Yeah, I'll let you continue.
I was just gonna ask you something in a minute.
Oh,
But,
sure.
Have you been trying to the gym clubs?
yeah, I have been.
I
Yeah.
was away in India in the last few weeks.
Oh, really?
That's
Oh,
why
okay.
I wasn't here.
So you're recovered from the time zone change coming back? Or?
Not yet, because my son is not recording. It's impacting me.
Yeah, yeah. Oh, I see. Yeah, good for you. Because, yeah,
Did you talk to that?
don't have one yet. I'm still looking.
Did you talk to that?
I did briefly, but I don't know. I keep getting different messages about whether they want to expand or not. And so I'll wait for you. Okay, thanks. So maybe I just need to be a little more assertive about it. You may not have realized that it's really kind of asking.
Yeah, I think so.
Do you think that's interesting?
The thing is,
We gotta get.
I will bring it up as well because I think the demand is so much.
And it sounds like, that even pediatrics, especially,
Yes,
be an ideal fit.
especially for
And I'm still very interested, and I'd love to have a more stronger academic ties than I've had in many years.
I didn't even to talk to Dr. Brown. She was the head of medicine.
So
I really want to push this. I'm just waiting for the holiday season to
Oh, sure. I know this is like
down.
the wrong time of year in some ways for me to be looking, it's like low season. But on the other hand, to be ready for spring,
Exactly.
hiring needs to occur soon to get something integrated.
Maybe you need to be a
But yeah, I think I do.
pointed it out.
Yeah, I looked at Valley, and they were advertising a position for a while, and it just went absolutely nowhere. I had this great talk with the recruiter, and next thing you know, it was like dead
We're
end.
going to hire somebody. I mean, she's a friend of mine, the physician who's already working there.
Yeah.
She's also moved from New York.
Oh, okay.
Okay.
So I don't know if I've met her before or not, because I don't know who it is.
She's a good friend of mine, actually.
Oh, okay.
So she told me that they were hiring.
Yeah.
I don't know if they might have already made a decision.
Yeah, I'm not sure what happened there, because they did hire someone, and so it didn't go anywhere. But I thought, wow, not even an interview. I thought my credentials were strong enough to do that, and I just really wondered what happened. But I don't know. The recruiter was great. I mean, it was really nice job.
I'm sure they will be expanding. I know that they might expand more.
Again.
Yes.
I see. Yeah, so I'm desperately trying to hold on.
So are you still with Dr. Wade?
Yeah.
How's it
It's
going?
horrible. It is just, I can't say how bad it is, which is why I'm desperate enough that I'm looking now anywhere in the country for locums positions. They don't want to get tied into something to stay here, but they just have to come out. Because, if you're not even making minimum wage, half the time you can't pay the bills. And it's just extremely stressful. So I'm not saying anything negative about him as a person, I'm just saying business.
Is your family still in Spokane?
But no, here in Seattle.
Here, they moved out.
But-
Oh no, they were here and you were in Spokane.
Walla Walla is actually where I was. Yeah, you remember East Side.
Yes.
Yeah. But So so it's really nice being back with my family, of course. But I got to pay the bills, and I'd like a more fulfilling work environment that's busy and teaching environment is also a plus.
While you look for these, I think this is still a long shot. Opening a pediatric position is still a long shot, but I think that's something to explore. And I need to work for a few other reasons as well. I'm definitely going to bring this up. I had mentioned this to them a few months ago, and he was actually excited. But you know how it is. If somebody doesn't push and follow on the engineers, you don't put your heart.
Yeah.
It's not going to get done.
And with all the distractions in life, including kids, it's hard. I understand.
And they asked me if I want to start a position last year.
Oh, did they?
If I want to start, but right now I don't have anything. I would be very happy to have a clinic there, but I don't have
And this is Bellevue, right? You were saying?
No, this is not. Yeah, Roosevelt.
Yeah.
Roosevelt is in Utah.
Oh.
Right now I'm in Bellevue.
Yeah.
Bellevue and some of my clinics are in Utah.
But the pediatric need, was that on the east side, or was that actually over there?
Roosevelt.
Okay.
Roosevelt.
Yeah, yeah, okay, I didn't realize it was that close. I mean, I live in Barhurst, right by Children's.
Yeah.
So,
Roosevelt is
yeah.
a few blocks away from.
Oh, okay, yeah, yeah. It's a nice clinic.
Yeah. They actually suggested their clinic. I was, I had these thoughts, but at the same time they also asked me if I can start a pediatric allergy clinic there because the need is there. And I said, I'd be happy to. I speak to the leadership. I spoke to them and they were excited about it, but they said right now the plan is to, really expand allergy and also make sure that we have such concentrate on that. I didn't say expand, concentrate on allergy section, and we'll revisit this topic starting on pediatric allergy because those will later.
I see.
That's why I think we
Yeah.
restart the conversation.
Okay. Yeah, yeah. Well, I'm definitely interested. Very interested. My longer term dream had always been an academic position, but there just never was the interest in children in supporting a full time academic allergist, at least adequately. That was always the perception.
It's already said that we don't have strong pediatric allergy presence. Academic pediatric allergy presence in Seattle. It's such a huge area.
It really is. Yeah.
It's
With growing need.
Yes.
I just
that was very surprised when I came here.
Having been a part of the establishment for 15 years, I can tell you this, we, when I was part of them, just felt like we had control and had the best of both worlds, the private practice salary and the academic control, and, since the administration wasn't willing to devote the resources to a full-time position, it was great to have our clinical titles, and, I'm kind of speaking in a negative frame there, but I really valued it because I really liked teaching residents, fellows, and other opportunities like that, but, my heart was also with children's, because I trained here in allergy, and I did a 5-year fellowship, physician scientist board at the time. I was thinking about an academic career, I think very seriously with the bench. But my projects just never quite took off that I could get successfully funded, so I ended up in the clinical world. But I did 5 years with a pulmonologist there, because I had funding through the CF Foundation of all things. So I've had a lot of strong ties with the clinicians and the children.
And also I think to pay children, that's why I'm not interested.
Yeah, right.
With, Seattle being so expensive.
Right. That's why I feel lucky that I got here, so long ago. We own our house, and we don't have high needs, in that regard. We're not trying to buy a house in this market with all the Amazon. Yeah.
We just moved here 2 years ago. It was so hard to find a decent price, nice home.
Yeah.
We ended up in Compton, which is nice.
Yeah.
Nice area.
Oh yeah, very nice area and great school system.
Yeah.
So, you did well.
Yeah.
but yeah, it makes your commute longer.
Yes.
Sure.
I mean, I don't come to Seattle often, so that's still okay.